Hi, I'm Mark, and I'm the human behind the podcast you're listening to right now. I'm really looking to learn more about what our listeners like and don't like about our shows. So if you're listening and you have opinions about these podcasts, I would love the chance to chat with you personally. There's a link in the show notes with how to get in touch, or you could email me at hello@lanternpodcast.com. Thanks. Now back to the episode.
282 confirmed cases, and 264 of them are in one province.
This is Ebola Watch, Tuesday, June 2nd. Today we've got Ituri's geography, a border crossing that's been shut for 2 weeks, MSF formally scaling up, and the first real readout on what's actually in the Bundibugyo treatment pipeline.
We should slow down on that 282 number for a second, because yesterday we were at 134 confirmed. And before anybody starts drawing a straight line between those two, the counting method matters a lot.
All right, let's get into it.
From the Irish News.
At least 282 confirmed cases of Ebola have now been reported in Democratic Republic of the Congo's ongoing outbreak, authorities have said, as patients who recovered from the disease described their joy in interviews with the Associated Press. The outbreak remains focused in Democratic Republic of the Congo's eastern Ituri province, where 264 of the cases have been recorded, the Ministry of Health said.
On the DRC Ebola thread, authorities are now reporting 282 confirmed cases, with most of them still in Ituri. But I need to flag something before anyone treats that as a clean day-over-day jump. Yesterday's WHO figure we were using was 134 confirmed, and the Irish News is citing the DRC Ministry of Health for 282. So before we read that as a single-day surge, we need to leave room for different counting windows, or for a backlog of lab confirmations landing all at once.
Right. And either way, 264 of those 282 are in Ituri province. That's 94%. At some point, saying DRC Outbreak starts doing too much geographic work when almost every confirmed case is in one province. And I'm not saying that to downplay it. I'm saying it because the real question is whether the ceiling inside Ituri is the story, not cross-border spread.
Exactly. And when the ministry itself lists early detection, rapid isolation, and contact tracing as the challenges, that sounds a lot like an undercounted province, not a contained one. More than 1,000 suspected cases against 282 confirmed is not a number you just wave past.
1 confirmed death in Uganda, 42 in DRC, no approved treatment, no approved vaccine. And the Bundibugyo pipeline is still in development. So if somebody asks me, is this contained? I can't give them a neat answer from these numbers.
This one's from Kigezi television.
The temporary closure of the Uganda-DRC Bunagana border in Kisoro district has entered its second week, leaving many Congolese travelers stranded amid ongoing confusion over Ebola prevention measures enforced by both countries. Ugandan authorities continue to allow Congolese nationals to return home, while Ugandans are permitted entry after undergoing mandatory health screening and testing. However, several Congolese travelers report being denied entry by Democratic Republic of Congo, DRC officials, despite receiving clearance from Ugandan health teams.
The Bunagana update from Kigezi television isn't really a screening story anymore. It's a coordination failure story. Congolese travelers are clearing Ugandan health teams and still getting turned back by DRC officials on the other side. That's not a border closure. That's 2 countries running incompatible protocols in the same 50 meters.
And there are people literally stuck in no man's land right now, caught between a Ugandan clearance certificate that DRC won't honor. If the DRC-Uganda coordination framework Cassidy keeps pointing to is real, this is the moment where you can see it not working.
The Kisoro RDC is asking for calm, which is the right instinct. But calm doesn't fix a structural mismatch between 2 health bureaucracies. The consultations he's talking about need to produce one protocol, not 2 different ones at the same gate.
And while those consultations drag on, there are also reports of security personnel assaulting people trying to use the porous routes around the checkpoint, which means the closure is pushing movement underground, right into the kind of population geometry that made the Kampala exposures possible in the first place.
Bastille Post writes,
As of 28 May, 125 confirmed cases, 906 suspected cases, and 223 deaths have been officially reported across Ituri, North Kivu, and South Kivu provinces. However, the true scale of the outbreak remains impossible to measure. Extremely limited testing capacity and difficulties in accessing certain areas mean that figures must be interpreted with caution.
MSF statement, dated June 1st, out of their Hong Kong press office, is the formal confirmation we've been waiting for. They're scaling up in eastern DRC, working alongside the Ministry of Health in Ituri, North Kivu, and South Kivu. The part I want to underline is their numbers, because they do not match the 282 confirmed cases in today's Irish news report. MSF's figure as of May 28th is 125 confirmed and 906 suspected, and that gap is exactly the kind of distinction that gets flattened in headline counts.
So now we've got 125 confirmed as of May 28th and 282 confirmed in today's Irish news report, which is basically a doubling in about 5 days. Either testing capacity suddenly improved, or the outbreak accelerated, or both. And MSF is explicitly saying testing capacity is extremely limited, so that jump gets harder to read, not easier.
Right. And MSF names 2 specific health zones where cases are rising, Mongwalu and Rwampara, both in Ituri. That's the sharpest sub-provincial geography we've gotten so far. Put that next to 264 of 282 confirmed cases sitting in Ituri, and this is not really a 3-province outbreak in any operational sense yet. It's an Ituri outbreak with tendrils.
And MSF is also the first ground-level source to say it plainly. No approved vaccines, no specific treatments for Bundibugyo. Not a policy memo, not a travel advisory, an organization with people on the ground saying that's the shelf they're working from.
The Herald writes,
Unlike for the more common Zaire strain, there are no approved vaccines or treatments for Bundibugyo. A small number of experimental vaccines and therapies are being assessed, and global health authorities are examining whether any existing Ebola treatments might offer protection. So far, supported only by limited animal data.
Reuters put out a structured FACTBOX yesterday on what actually exists for Bundibugyo. Vaccines, treatments, the pipeline, and the headline answer is still no approved anything. No licensed vaccine, no licensed treatment, fatality rate up to 40%.
And the pipeline is nowhere near the finish line. Most of those experimental candidates haven't been tested in humans yet, which means anyone deployed in Bunia right now is looking at emergency or compassionate use authorization as the best-case scenario, not an approved drug.
The WHO did recommend prioritizing specific experimental antibody-based drugs, which is a more concrete signal than we've had. But prioritize for assessment and deploy in the field are very different rungs on that ladder, and we're still on the first one.
I keep coming back to the virological preprint. The reservoir host for Bundibugyo is still unknown. If you're designing a vaccine without knowing the exposure pathway, you're building around a gap. And the FACTBOX doesn't solve that. It doesn't tell us which candidates actually account for that uncertainty. When I look at outbreak updates, I keep seeing 3 different numbers: confirmed, probable, suspected. And I honestly don't know which one I'm supposed to be paying attention to. What's the actual difference?
Absolutely, and mixing those up is how you end up with wildly different sounding headlines about the same outbreak. So here's the framework public health agencies use. A confirmed case means a lab test has come back positive. Full stop. Per the UK Health Security Agency's case definitions, that means an individual, alive or dead, has a positive result from an approved diagnostic test. A probable case usually means someone has symptoms consistent with Ebola and a clear epidemiological link. Say, direct contact with a confirmed patient, but the lab result hasn't come back yet or couldn't be obtained. A suspected case is broader. The clinical picture is there, fever, severe weakness, sometimes bleeding, but the exposure history is still being sorted out. The European Union's interim case definition for the current outbreak, which involves the Bundibugyo virus strain circulating in the DRC, uses that same 3-tier structure to separate people who need urgent investigation from cases where the evidence is stronger. And these categories are not permanent labels. They move. A suspected case can become probable once contact tracers confirm an exposure link, and then confirmed once the lab speaks. The reverse can happen too. A suspected case can be ruled out entirely. That's actually a sign the system is working. In the current DRC outbreak, The South African NICD's situation report from May 29th notes 8 laboratory-confirmed Bundibugyo virus cases reported from 3 health zones in Ituri province. That's the confirmed count. And it matters a lot not to fold suspected or probable figures into it.
So when a suspected case gets reclassified, either confirmed or ruled out, does that change the official outbreak total? And can it make an outbreak look like it's shrinking when it isn't?
Yes, exactly. That's why WHO and national ministries publish the 3 counts separately, instead of giving you one blended figure. And why you should be skeptical anytime a headline just hands you a single number, without saying what category it came from. What to watch next is how the probable and suspected columns move relative to confirmed. If the suspected pool keeps growing, while lab confirmation lags, that can mean a detection bottleneck or real spread. And those are very different problems for the response. If you like concise daily briefings, try Iran War Daily, a foreign affairs update on the U.S.-Israel-Iran war, from strikes and ceasefire talks to oil markets and Hezbollah spillover. Find it wherever you listen to podcasts. You'll find links to all the stories we covered today in the show notes. If one caught your attention, they're there for a closer read. That's Ebola Watch for this Tuesday, June 2nd. This is a Lantern podcast.